On this episode of the Ask Mike Reinold Show, we talk about patellar tendon grafts, we talk about periodization for inhibited muscle groups, and we talk about asymmetries in athletes and what to do about it.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up here at Champion PT and Performance up in Boston, Mass. We're here with Mike Scaduto, Dan Pope, Dave Tilley, Lenny Macrina. All the PTs at Champion are in the house today. Big student crew. This is the backwards episode. We're doing Lexi Malone from Simmons College. Nailed it. Travis Stepp from the University of Kentucky, and Matt Kelly from Dalhousie University in Nova Scotia. Nailed it. Took me a few episodes, but I got it. So, all right, what do we got for questions? Travis, you starting it today?
All right, we got it. Storm from Tennessee.
Wow.
Got a neat question.
Storm, love it.
On an earlier podcast, you addressed bone patellar bone autograft likely being the best ACL replacement option for the younger active population. Some surgeons claim this method results in significant patellofemoral issues like pain and arthritis down the road, leading the surgeon to prefer other options. Do you find this to be true, or is it mostly dependent on post-op therapy?
All right, so bone patellar bone autograft for ACL reconstruction. Len, what's the science showing of that graft getting arthritis down the road versus other grafts?
Yeah, there was actually just a paper that just came out. I think it was AJSM. I think I tweeted it recently.
Not that we're
going to use time, right?
But
there is a recent paper that just came out that did show a higher incidence of patellofemoral arthritis in the post-op ACL using a patella tendon graft. But to me, I think as the field of PT and just us in general, there's a reason why our re-tear rates are so high, and there's a reason why our long-term results are not so good. I think we're still struggling with rehabbing this population of people, with getting them back too soon potentially, with getting them back without a sufficient quad and glute strength. So I think it's not just one thing. I don't think the patella tendon graft is causing patellofemoral arthritis. I think it's a mix of everything, that there was a traumatic injury to the joint. We throw off the homeostasis to the joint. The mechanics in the knee joint may be altered. They're getting back too soon with too high forces through the joint. And so I think it's a combination of everything that potentially is leading to this higher incidence of OA.
Right, and maybe we're getting lucky with the other grafts because maybe patellar tendon grafts need a little bit more skilled rehab afterwards to assure that you're getting good patellar mobility. It's not getting scarred down.
Personally, I don't see a lot of anterior knee pain in my patella tendon grafts. Maybe kneeling on it, but I think that's common.
Yeah,
so
you're
whatever.
kneeling
Of
on
course,
an
you're kneeling on where they did the surgery. So otherwise, I just think we're doing a disservice by not loading the joint sufficiently. Maybe we're getting them back too soon. Tim Hewitt talks about getting them back 2 years out of surgery is going to be optimal, which I don't know if it's realistic, but
Come on, Tim.
the
Come on,
research
Tim.
he is saying is 2 years out. But who can blow 2 years of their life with college and high school sports, and scholarships and all that stuff? So,
Makes sense in a lab setting.
right.
Wink,
So
wink.
there's obviously going to be huge discrepancies in the pendulum swinging way too much in one direction. Were we too soon? Are we going too long? I think somewhere in the middle, 12 to 18 months is probably going to be your sweet spot.
I don't know if we have good enough science yet showing it's definitive, because you can say that it's hard to control a study like that. So, again, I would just reiterate with what Lenny said. I feel like we don't have a lot of those issues with patellar tendon grafts just because we're so on top of their rehab early on. So I would say focus on that. But Matt, what do you got?
Giacomo from Toronto says, "Hi guys, really enjoy the podcast and the other courses you guys put out. My question is about periodization and where to start an athlete or client. When we are looking to target an inhibited or underactive muscle, what scheme should we be using? Is it okay to start with whatever set rep scheme allows them to properly facilitate the muscle and then move to a 5x5 for strength?"
Okay, yeah, good question. So that's funny. We got Matt the Toronto question. That was perfect.
Do you know Giacomo? I don't. You don't know?
I don't.
Maybe I should reach out.
I will say I'm going to give Giacomo some credit because I think he's heard us destroy some people's names before. In parentheses, put how to pronounce it, which ironically I actually knew how to pronounce that name. But funny that they did that. So all right, so inhibited muscle group after surgery or injury. Yeah, how fancy do we get with set rep schemes?
I'll weigh in because I think I made this problem because when I had just come out of school I was on the SFMA and I was like going patterns and ignoring isolation exercises, and I think that when someone's getting back to the basics and they have a lot of inhibition from swelling, isolated at lower intensity for longer volume and higher reps is really what they need to feel confident in their limb, whatever injury they have, and get some like neural drive to the tissue. So I made that mistake, and I don't want people to make that. It's like the boring basic cuff stuff, then the extensions, the hamstring curls, like it has its value before you start doing crazy pattern assist stuff.
Rolling.
Yeah, all that.
The Norwegian approach, which is interesting. So sets like 30 are part of it's all about neuromuscular repatterning, and that's repetition based. So if your primary objective is inhibition, right, muscle's not working well, I don't think you're gonna get a muscle not inhibited. What's the opposite of inhibited? Facilitated. Excited with 5 reps. I think you need more reps than that. So. Nice, I like it. Lexi, what do we got for number 3?
All right, Margaret from Chicago. In a female gymnast with SI joint pain, how significant would asymmetrical hip external rotation at 90 degrees of hip flexion influence continued symptoms and pathology? If a factor, would you start with stabilizing the hypermobile hip or improve the mobility on the contralateral hip?
All right, good question for lots of reasons. So a female gymnast.
Mike, what do you got?
Dave's
Take this one.
look at he's sweating, he's nervous. So a female gymnast with SI pain, which I think we can say, let's just call it lumbopelvic pain, right? We won't say it's necessarily her SI pain. She has hypermobility of external rotation
At 90 degrees.
at 90 degrees. So it's interesting. And then I think this is the real part of the question that I like. Do we work on making her symmetrical? Do we work on making the other side more mobile, or do we work on that side being more stable? What do you think, Dave?
So there's a few layers. The baseline is that all of the external rotation assessments, the laxity testing, all that stuff is going to completely miss the boat if you don't look at volume. I think that a lot of issues in gymnasts come from they're doing too much of the same thing over and over. And I have made the biomechanical mistake of trying to pick apart all the little SIs, IRs at 90 or 0, and you come down to it, it's like, well, you're doing 500 volts per week. It's like, okay, well, it's never going to fix itself if we don't address the volume and what they're doing in the gym. So that's one layer. 2 is that gymnasts do have a dominant leg. They hurdle with one leg for 18 years. You're going to have weird pelvic obliquities, and they always want to see motion that's symmetrical in all planes, but it's just not going to happen in a gymnast because just like a baseball player has changed that way, they hurdle with one hip for 20 years, and it's going to be always weird on one side. I think that's an important thing to consider. I will say that I do think that they lack a lot of strength, dynamic stability, and true just hip baseline strength in their glutes and in their kind of like hip rotators, and that causes a lot of issues, micro instability, overuse type stuff, because the ligaments and the joints just get beat up a little bit. So I would say bigger thing is periodization and what they're doing for volume. In the middle is not everyone's going to be symmetrical. Just like if you correct the baseball player's IR too much, you're going to blow them up. And then third would be like, okay, now that we have those as a backdrop, maybe yes, we can do some strength, stabilize it. So maybe she's getting a little tweak when she's doing some larger motion skills in it from her laxity. And so I would say a lot of strength. I do a ton of hip strengthening here, like a lot of volume, because it's missed in gymnastics. So
you brought up some great points, and you brought up the baseball thing a little bit. And that reminds me, literally, I don't even remember, 10 years ago or whatever. I remember in one spring training we had all our physicals on our baseball players. So the entire organization, tons of guys, just physicals, and we're looking at all the data, and we get this big whiteboard out, and we start talking about what does a baseball player normally look like,
right.
And then we say well, what enhances performance, and let's just use one example. Let's just say shoulder external rotation, right? You need shoulder external rotation to throw a ball, but you have more on the right than you do the left if you're right-handed. So our big question all right, well, do we work on making them symmetrical to potentially I don't know,
Yeah.
decrease injury rates, or do we actually facilitate more asymmetry to make them better at their sport? You know, it's a super question. I still don't know the answer.
It's really hard. It's really hard for other sports. I think you have the background that you've seen what normal people not in pain are, which
Right.
is challenging for us because if somebody walks in with hip pain, is it the chicken or the egg? Is it they had hip pain
Right.
and it caused some stiffness, or were they stiff that caused their hip pain?
Right.
It's like, who do you know? So I'm trying to get better at seeing people who aren't hurt with normative data, but sports don't really have that. So it's easy to pin that like, oh, well, your hip's super lax in this motion. Like maybe they're tight. Maybe that's tight for them.
Right.
You know, who knows? So
Right. Yeah. No. Interesting.
sorry for a dodgy answer.
Yeah. Well, I don't think we know the answer.
Yeah.
I think that's okay. But we.
It depends.
Well, Dave said it right. There's probably way more going on than that, and
Yeah.
we're just looking at that little thing. So is that 3? That's good. Awesome. Another great episode. Thanks so much. Head over to MikeReinold.com. Click on that podcast link, and there'll be a nice form you can fill out to answer us questions. Been great questions, so keep them coming. They'll be great. Head to iTunes and rate and review and subscribe or whatever. And we'll see you guys on the next episode. Thanks so much.